have never met a stronger, cooler group of people than my clients. I was a little bit nervous when I started because I also didn't learn much about psychosis because people are afraid of it and the research is limited. So just jumping in head first is just scary. And then you see these people that are just people struggling with something that is coming from somewhere.
This podcast is for informational and entertainment purposes only and is not a substitute for professional mental health advice, diagnosis, or treatment. Consult a qualified professional for your needs. Views expressed are those of the host and guests and not necessarily those of Meet Your Mental Helper Podcast LLC or its affiliates. We are not responsible for actions taken based on this content.
Hi, I'm Jim Weisbecker. I'm a licensed professional counselor in Arizona, Colorado, Florida, and Ohio. The reason I started the Meet Your Mental Helper podcast is kind of selfish in a way because I just love talking shop with colleagues. But I also think the world needs to know about some of these people. And the reason I say that is I'm amazed at how much they know. And I think to myself, they should be on a podcast. But they're not celebrities. They're just everyday counselors, therapists, coaches, psychologists that work in our communities and grind it out to help us heal and to help us grow. So let's meet today's mental helper. Welcome to Meet Your Mental Helper. Today we have with us Camryn Bryan. And Camryn, for listeners meeting you for the first time, how do you describe the work you do with the people experiencing psychosis?
Wow, yeah. I have a pretty vast role. Primarily, I do peer support. I am also a graduate student therapy intern. I run groups. I do community outreach and education and cover some case management things here and there. So I am lucky to see the whole scope of psychosis care.
Great. And just to ground listeners, Camryn works in First Episode Psychosis program, supports individuals navigating psychotic symptoms, leads community education, as she just mentioned, to reduce the stigma, and is currently pursuing her graduate degree in clinical mental health counseling. You're busy.
No kidding.
Yeah. So tell us a little bit about, I know you offer support services, skill groups, and First Episode Psychosis. Maybe for people listening, let's kind of talk about what is psychosis, first of all, for, people that maybe aren't familiar with mental health.
Yeah, so psychosis is generally thought to be a disconnect from reality. This can look like hearing voices, seeing things. It can feel like one's body is moving when it's not, disorganized thoughts. It can look a pretty wide number of ways for different people, but the main thing is that there is a separation between what is real and what's perceived.
Okay. So that's kind of the key ingredient.
Yeah.
And how does that show up is there kind of a common way that shows up?
In my work as a first episode specialist, I typically see people directly after hospitalizations. So that's when symptoms are pretty acute, which like a lot of difficulty functioning through life, just a hard time taking care of oneself, confusion, fear a lot of the time. It can be really hard, really traumatic for folks. So it looks a lot of ways and also can be fairly bottled into anxiety disconnect symptoms.
I could see where experiencing that alone could be its own trauma.
Absolutely. And that's something that I think is very interesting because we treat trauma very differently than we treat psychosis in the field. We see a lot of emerging mind body work with trauma because we're recognizing the nervous system and how it shapes the brain, but experiencing this disconnect that can come with a lot of delusions. And in the US, we see a lot of persecutory delusions, which can look like people being afraid that the police are going to come get them or that somebody is going to injure them. And that's so real for these people. This is their experience. And if we think about that happening in consensus reality, that would be considered a trauma. So that lives in the body.
Hmm. So when a first episode happens, how many people are aware that this is actually happening? That they're having an
Mhm.
episode, or how many go that they're not? And does that kind of make sense? How many
Absolutely.
recognize it? That's where I think that would be scary.
Yes. So it a lot of my answers for so many questions regarding psychosis are it depends, which is unfortunate. But a lot of the time when psychosis kind of starts to develop, it can look like a lot of other conditions. So we see a lot of folks presenting with ADHD symptoms before they have their first episode. And do we consider that an episode? Not necessarily, but we can see people inching towards it. And then when someone has their first episode that would be meeting diagnostic criteria, people tend to notice because that criteria is pretty specific and intense, but I feel like there isn't enough information out there on how we can recognize this coming before it can really get scary for folks.
Hmm. When you're talking about diagnostics, what's the common is there a common disorder given to psychosis? For example, you were mentioning being scared of the police coming to arrest you. Is that schizophrenia? Is it, or what's a common one?
Yeah, so schizophrenia is the primary diagnosis that we see for people in psychosis, but there's a pretty fascinatingly wide range of diagnoses. Schizoaffective disorder, which is kind of like a mix of schizophrenia and bipolar. We can have bipolar with psychotic features, PTSD with psychotic features. There the field is very much expanding on our understanding of psychosis and how that can be applied. So it's kind of ever changing, but
Sure.
yeah, very applicable to way more people than we would imagine.
Yeah, and is it uncommon or common to find people with psychosis connected to substance use?
Mm. So it is quite common. There are substances that are much more likely to trigger psychosis in people that are, I guess, predisposed would be the word.
Sure.
So methamphetamine is one of them. Cannabis is one that we're seeing increasing very quickly. And folks with psychosis, there are studies that have shown them to be more likely to use nicotine, and this can precede the psychotic symptoms, but
Hmm.
causation or correlation, who knows? But it's interesting for sure.
Nicotine in addition to cannabis, or just by itself?
Either one.
Hmm. Yeah, I always tell clients, this cannabis you're using now, since it's legal almost everywhere, is so laboratory,
Mm.
They're crossbreeding strains and they're refining it in ways that I always tell them that my, older hippie cousins never would have dreamed of having. And I have a lot of clients that are, that have been heavy users who will have some moments like that.
Yeah, absolutely. And it's fascinating with how it's been chemically engineered. The amount of people that I've seen come to me for psychosis support after using a dab pen maybe once or twice is fascinating. The higher the concentration of the cannabis, the more likely it is to trigger an episode.
Yeah, it's
And
kind of the irony, isn't it?
right?
I've always been very pro, like, let people use cannabis if they want, but then legalizing it has actually made it more, I don't want to say lethal, but very, very potent.
Yeah.
I notice a lot of paranoia with
Mm.
heavy users, and they're even admitting it. I'm not paranoid or anxious than I smoke to relax. And I notice I'm more paranoid or more anxious. So
Yeah.
it's an interesting flip as to what we're seeing with that.
Yeah. I think just being informed and allowing people to make those decisions for themselves can be really big because there are some conditions that can be treated by medical marijuana. That's great. And we need to know the risks associated.
Yeah. Yeah. I think we went through a period there where it could do no harm
I know.
as we were getting there. So you do both individual work and groups, is that correct?
Yes.
How do you decide where somebody goes, or do they do both?
Um, I think it depends on the client's individual goals, where they're at with their symptoms, how they interact with people interpersonally. So I'm a big fan of groups. I think that it's great. Socializing is a huge protective factor, and you get to learn so much about people through how they interact with others. But also, if we think about paranoia, it can be really hard to sit in a room with so many people. So, recognizing where the client's at, talking to them about it,
Hmm.
and also just each individual group has different energies depending on what the topic is or which clients are there. So, there are a lot of factors, but
Yeah. And what makes first episode psychosis education especially important early on?
mm, yes. So, there are a few kinds of education that I think are very important. What I do is I connect with agencies in our community to partner with our care team and teach how to recognize these early symptoms and how to get people help in a way that will actually help. A lot of the time, we see a first intervention coming from the police because our system in an emergency, who are you going to call?
Hmm.
And that can be very hard for clients and cause them to drop out of services if that's something that's really scary for them. So,
Sure.
partnering with hospitals, schools, peer support agencies to know how to recognize it super important. And then educating the client and their family is a massive piece because lack of insight into one's illness is a symptom for psychosis. And having an awareness of what's happening in your own brain can really help someone understand and take back some control over what's happening to them. And family support is so huge. There have been so many studies that show the impacts that families can have when giving that support.
I imagine that's a challenge too, because somebody having psychosis is not going to be maybe easy to be around. And do you find that's a challenge with educating families?
It can be difficult. We think about how people are uncomfortable with what they don't know. When someone is completely detached from the reality that we're seeing, that can be really stressful. And if that person is scared and their nervous system is activated, our nervous systems are probably going to become activated.
Mhm.
And it just can spiral when we don't know what to do with it. So, kind of helping families learn how to care for themselves and each other while navigating this stressful thing. And especially, like, this is a loved one. That's so hard to see them going through this. And it can be scary and overwhelming and just all of the hard things.
Yeah, and I've heard people say, you know, my son or daughter said these horrible things to me or accused me of something, and it's so it's a but then they also, recognize they're having an issue, but it's tough for everybody because it's when you don't know who you're talking to sometimes, right?
Yeah, it's a painful thing for a lot of people to go through, and respecting all of the members of the community's experience with it can be really helpful because we'll feel really guilty saying, wow, this is really hard for me to be around. Like, that's your child. You're there to support them. And if you're having a hard time, it's important to recognize that so that we can balance out and have everyone be there for each other. Because again, when your nervous system's activated, it's going to activate everyone around you. And then there goes the family system.
Yeah. In your work, do you see a particular population, or is it?
Yes. So I serve individuals mostly from 15 to 30. That's when most first episodes occur, usually on closer to 25 for women, a little bit earlier for men.
And when you mentioned earlier, part of it's telling them what's going on in their brain. What does that look like? I mean, maybe pick a specific type of. I know there's a lot of variation, but
Yeah. I the nature of psychosis research is evolving very quickly, which can be another challenge in helping people understand what's going on in their brain. I like to really focus on what language the client uses in interactions before I try to help explain, provide psychoeducation, because if I just throw a bunch of big words at someone, that's just going to make things way more stressful. So
sure.
if a client is coming to me saying, I have really scary thoughts in my brain and they're saying really mean things to me, something along those lines, we can look at, okay, are these mean thoughts, does it sound external? Is it coming from inside of you? Are you kind of consciously making these thoughts? And then go from there, explaining, like, hey, your brain is doing something and it is not your fault. And there are ways to deal with it. That is a big starter, is this is your brain, not who you are, which is
Yeah,
a complicated one.
right. And I've found that through the years, somebody will say, I keep getting this message to do XYZ. And it's
Mm,
tricky because sometimes I'll say, well, is that a thought you're having, or is it a voice you're hearing,
mm.
or what is it? And oftentimes that's a tricky one where they're not sure.
Yeah. Something else I really like to explore with those kind of callings or symptom content is where is this coming from? Because while psychosis is a disconnect from reality, one's brain can't just make something up that doesn't exist in their world. So they are getting this information from somewhere. I hear plenty of people say, like, God is calling me to do this thing. So I like to kind of understand, where is this coming from in their life? Is this just something that they've heard in society? And what kind of feelings are coming from this? And what feelings is this coming from?
Mm-hmm. It's do you have a specific like protocol you use in figuring that out, or just varies by person?
Definitely varies by person. I like to take into account demographic, culture, life experiences, kind of just looking at the person holistically, taking into account health, physical, nervous system states. There's so many things that we can look at, and it can
Mm-hmm.
be overwhelming for the client, the provider, anyone. But once you get a lot of practice doing it, it becomes kind of an automatic thing that you gather while getting to know the client like anything else.
Sure. Is there a particular type of client that benefits the most from this education, do you think?
Mm. Yes. So I think it's important to always meet our clients where we're at. And some people aren't in the space to be educated on something like this. And that's
Mm-hmm.
not to be confused with infantilizing people with mental illness and assuming that they can't learn this information. It's more so being attuned to what other information are they able to take in. If they're completely disconnected from reality, can barely hear us, only talking about one thing specifically, it's probably not going to land. If it's going to trigger them, or if they have delusions regarding,
Mm-hmm.
I guess, the more scientific aspect of illness, that could be something to look at. But following the client's lead, seeing what they're able to process.
In your work, are you dealing with mandated clients? You mentioned earlier, sometimes the police are the first ones to encounter this. They're out in public having an episode, and maybe it's scary to people around them. Or are most of them voluntary, or both?
Um, it really depends. I have a few that are mandated. I have a few who have been referred by doctors, family members, and some people even seek out services for themselves.
Hmm. And with a psychosis episode, is that does that include dissociation, or is it a separate thing?
I would consider that a separate thing. We can see plenty of dissociation in schizophrenia, but where the two pull apart is pretty specific. Dissociation on its own wouldn't be considered psychosis, but it is something to look out for when assessing for psychosis.
I remember, this goes a long time ago, a person telling me they from time to time maybe they weren't voices speaking to them, but would hear conversations around them.
Hmm.
Is that anything that you notice? Or and they said it's not even clear what the conversations are. They always had like a sense of, at different times, if they were doing something quietly, these conversations kind of like around them.
Yeah, definitely common. Definitely common. We see
Okay.
a lot of auditory hallucinations, and many of them can't really be deciphered by the client. They don't understand what it's saying. So it can be disorienting for the environment that they're in.
So that's a fairly common symptom sometimes.
Yeah.
Gotcha. Talk about your own experiences in mental health and how that's kind of shaped your work with this.
Yeah. So my own experiences in the mental health field have been very interesting. I decided that I wanted to be a therapist when I was about 5 years old.
Wow.
I know. I said I will either be an emotional support dog or a therapist, and the other one doesn't seem very doable. So here we are. I kind of, I guess, began my journey with dealing with my own CPTSD when I was about 5, and I didn't want other people to go through it, and I didn't have words for that other than I want to be a service dog. Um, and growing up, I was kind of in and out of therapy until after quite a few more traumas, I, as a teenager, wound up in what we usually in the field call the troubled teen industry, which is a very interesting place. Many fascinating documentaries out there. It's known to have some ethical challenges. And as a teenager, I was pretty shocked by the system that I was thrown into. And I am very, very lucky because the therapists that I had were such wonderful people trying to navigate such broken systems that while they're healing me, I am getting hurt at the same time by the system. And I just did not like it. So
Yeah.
I turned 18, aged out of the program, and immediately went to go get my bachelor's degree in mental health counseling because I did not like what they were doing. And
What
I,
can you give
oh,
us
go
some
ahead.
examples of what was frustrating about that?
Yeah, yeah.
The
So,
system.
yes. Where I was, there was a lot of public shaming and humiliation as punishment for very, very normal teen behaviors
Mhm.
and symptoms of trauma. I was told that I made up my trauma for attention.
Wow.
Yeah, a lot of privileges taken away. So it
So
was
it was a very punitive situation.
right. Yeah.
Gotcha. Yeah, that is hard to fathom.
It was shocking. And when I was there, I was already, I mean, I had wanted to be a therapist my whole life, but I was like, okay, we are going to put this into motion and here's what we're going to change. And in undergrad, we were asked to consider what populations we would want to work with. And
Mhm.
never once did I think psychosis. I thought, I'm not cut out for that. I would not know what I'm doing. And then after I graduated, I applied for a job that said FEP in the title. Did not know what that meant. Apparently, it is first episode psychosis. They asked how I felt about working with psychosis. I said, good. And now seeing so many parallels between what I had gone through and the way that the field overwhelmingly treats these people as just scary, dehumanized pathology. They deserve so much better.
Yeah, so your experience as a teen, it kind of you saw the same pattern with psychosis.
Yeah, I see.
Clients or yeah.
Yeah, there's a lot of treatments that can be unethical, pathologizing, and
Mm.
forceful,
Mm-hmm.
which is hard for folks.
Yeah. What do you notice today? And you mentioned there's a lot of emerging research on it, but it is definitely something I think a lot of people in mental health, that's not the area they want to, deal with. Just like, I remember in my practicum, nobody wanted to deal with court mandated sex offenders, or I don't want to work with that population. And it's understandable, but I think to some degree it's similar to psychosis. It's like, am I going to get attacked? Am I going to have somebody, lose it, go sideways on me?
Yeah. And that's something that is so perpetuated in the field too. People with psychosis are far more likely to be the victim of violence than the perpetrators. And working with these people, I have never met a stronger, cooler group of people than my clients. Like, I was a
Hmm.
little bit nervous when I started because I also didn't learn much about psychosis because people are afraid of it and the research is limited. So just jumping in head first is just scary. And then you
Sure.
see these people that are just people struggling with something that is coming from somewhere.
Yeah, and I'm thinking back to my own studies when I was getting my master's degree in this, and I don't recall a lot on that, to be honest with you. A lot on psychosis. There was, except for, when you're studying the DSM and what constitutes this and what constitutes that for a diagnosis. But yeah, I mean, we had classes on about everything: substance use, sexuality, anxiety, depression, trauma, everything. But I don't remember a lot on that, to be honest with you, which is one of the reasons I think it's interesting to talk about it.
Yeah, I hear that from my colleagues too. I actually heard that from someone earlier today who is going through grad school right now.
Hmm.
And it's so interesting to me that we don't talk much about it. And I'm learning new things every day, neurobiologically, spiritually, that we just don't talk about. And it makes working with these folks scarier for clinicians because
Hmm.
psychosis is so mystified and stigmatized when in reality, it is just the human brain.
Hmm. And then you have, the social media influence where somebody will repost a person in somewhere that, grabs a lead pipe and starts hitting people on the bus. And then everyone that has psychosis is that person.
It's
Right.
so devastating when
Hmm.
people do that because we do not know the whole story there. We don't know what the person is going through. And then people with psychosis, when they get the diagnosis, they think, okay, well, that must be me then. That is so terrible to watch people reckon with. Like, it is a mental illness, just like any other illness is an illness.
Yeah. I never, thought about that, but when people are diagnosed with it and they're able to say, okay, this is the form of psychosis I have, maybe it's schizophrenia or schizoaffective disorder. What is that usually like? Is there relief, or do you think there's their own fear of where can I end up?
Yeah. The majority of the time, what I see is almost a type of grief and struggle to understand. It can really shake someone's entire identity, which is already hard for people experiencing a disconnect from reality. There's so much acceptance work that we do, and a lot of the work is reminding people a diagnosis is a word to describe a group of symptoms. It is not your entire person. You are a lot more than psychosis. And just because you have schizophrenia does not mean that you're scary, dangerous, or a burden.
Yeah, I remember my early days when I worked in community health. I ran some groups, and I had a person who was. I remember one morning I parked in a different spot. I'm walking in the front door, and this person was having a big argument with
Mm,
an invisible person, really animated. And I thought, oh, great.
yeah.
And then I thought, you know what? Let's just try something. So I walked up, and as the argument's going on, I said, "Hey, so and so." I go, "Good morning." And all of a sudden, it was so amazing. Their face changed. They go, "Oh, good morning."
Yeah.
And I said, "I'll see you at 10 o'clock." Yeah, I'll be there. And then as I went through, it was like double doors, and looked back out, the argument had resumed. It was back to, and that was a big eye opener to me, but I just had to try it, because at
Yeah.
first I thought, I thought, well, I've got to go to work, and I know him.
Yeah.
But that was a real eye opener, just the way everything changed for that brief moment.
Yeah, that connection can be really big for people, grounding them back into reality and having another human's nervous system to co-regulate with, and just to see like, oh, okay, so there's an argument happening in my brain, but that doesn't necessarily mean that argument is my entire reality right now.
Yeah, and you mentioned the nervous system a lot.
Mm,
I do a lot of trauma work, EMDR, whatnot, and years some years back I took a training, and I keep forgetting his name. I want to give him credit, but one of the trainers had a saying: "The strongest nervous system in the room wins."
yes.
And in your work dealing with people every day, how do you make sure you're regulated in a dysregulating environment?
I honestly think that personal regulation is one of the keys to psychosis care. I had been asked quite a few times when I first started working with psychosis and didn't have the language to describe this. How do you engage people so well? How are they feeling comfortable with you? What are you doing? I'm like, I don't know. But it's like sharing that stability with the person in front of you is huge. Because when you're in a different reality, your nervous system is reacting to something completely different. And a lot of the times it can be scary. So showing up as a grounded, stable presence and consciously connecting with people that way it's been life-changing in my work.
Yeah.
I maintain my composure and my nervous system very carefully. I love therapy. I love providing therapy, and I love going to therapy. So, I guess really processing my own stuff, making sure that I am aware of my triggers and how I am going to be reacting to some of these things. As someone living with CPTSD, I have a reactive nervous system. It can be on edge. And I'm aware of that, and I know my triggers, and I know how to ground myself in safety, looking for the safety in that environment, bringing it into my nervous system and sharing that safety with folks is one of the biggest things.
Yeah, that's wonderful. This is kind of off topic, but I often find people with really regulated nervous systems, um, like animals will come up to them,
Yes.
or small children. That's
Yes.
been my experience. Like, I've had dogs come up to me, or cats sit on my laps when their owners go. They don't talk to anybody. or
Yes.
they don't interact with any humans. And like, like remember a friend had two cats. One, he said, is violent and won't come out. And then he went in to get me some water or something, comes back. He goes, why is that? I've had those experiences, and I just find, I'm not saying I'm like some savant of regulation, but I, um, I think that there's something to that. You said, I could tell you said,
I
yeah,
genuinely think about that fairly regularly because I am a huge animal person. Animals are usually drawn to me. A lot of the time, I'll be out in public and people will come up to me and just start sharing their life story. I'm like, oh,
yeah,
okay. Children tend to follow me places. I'm like, go to your parents, please. But
hmm
it's because I am fairly grounded. The idea of neuroception, so people's nervous systems scanning the environment subconsciously to make sure things are safe, that evolutionarily has a massive impact. So when you have a steady nervous system, what that says to the outside world is, I'm not being hunted. That means that you're safe.
oh, great point.
Right? So then if the person that others are drawn to gives off the energy of, I'm not being hunted, being in that presence, you're going to assume that you're not being hunted because there's a mutual understanding that there isn't any danger. And we don't have to talk about it. We don't even have to recognize it. But when we're able to bring that to a space, it's so powerful that it can draw in even animals. Like, they know.
Yeah, or small children.
Exactly. Yeah. It's like,
Yeah,
oh, look, safety.
that's a really interesting way you put it. For years I did industrial sales before I got in this world, and I found people would look at their watch and go, "I've got 5 minutes to talk to you," and then 45 minutes later they're telling me all their problems, which is one of the
Yeah.
reasons and I always thought, wow, that's interesting. Just buy something from me now.
Yes.
But talk about neuroception. Did I have that right?
Yes.
Neuroception. What for
Neuroception.
people that have never heard that term? How do you define that?
Yeah. So I would define neuroception as the body and nervous system, without saying anything to the brain, is constantly scanning your environment, other people, to take in as much information as possible to just automatically keep us safe. And an example that I think of is how trauma is stored in the body. Extended cortisol release
Uh-huh.
causes, you know, things to stay in your body so that you can bypass cognition. You don't have to think about it. There's a saber-toothed tiger. I'm out of here. When we have that on a large scale, or in people with psychosis whose internal landscape is traumatic, then we'll see that neuroception kind of shift to scan for danger. And that's where I see it appearing in the body, is subconsciously we're looking for danger. And then all of the sudden you don't even know what happened, but your body knows to get you out of there.
Mm-hmm. And with psychosis, is that a false alarm sometimes?
Um, so there, to my knowledge, hasn't been a ton of research
Yeah.
done on psychosis and neuroception, which is a path I would love to explore more. But I would imagine that it absolutely can be, as it can be for anyone. It's based off of our experiences. Our body takes our experiences and kind of turns them into frameworks of reward, something good happens, punishment, something bad happens. And everybody lives a different reality, no matter whether we're experiencing psychosis or not.
Sure.
And that seeps into our neuroception. So People who are afraid of clowns. Maybe you saw a scary clown movie back in the day. Your body may have stored that neuroception. And then when you see a clown, you're going to be terrified. And it's a false alarm.
Right. Right. And trauma, of course, is big for triggers. Do you think a lot of psychosis is untreated trauma, that it evolves or morphs into that over the years?
I think that it is very, very complicated. So PTSD with psychotic features is seen fairly regularly. So that is one concept of it. And then also, a lot of the people, the majority of the people that I see come in with trauma, whether or not it's a childhood trauma before psychosis occurs or something that's happened after. It's just about everyone I work with, and it's a huge risk factor for developing. So hard to say
Yeah.
chicken or the egg, where do we interact, but it is there.
Yeah, for sure. Um, Neuroception, you mentioned scanning. Are you talking about kind of eye movement scanning, or because there's certainly a lot to be, there's some new research that scanning right to left, that optical nerve relaxes the amygdala, that fight, flight, or freeze response. And I often find people who have panic attacks will tell me, I went to this place and just zeroed in on one thing.
Yeah.
I turned off my scanning. It was just tunnel vision.
Mm.
Is that kind of what we're talking about, or just part of it?
It's definitely part of it. On a very large and kind of vague scale, it's the entire body, all of our senses. Again, something that we're not even noticing is
Makes
happening.
sense.
So what are we hearing? What are the facial expressions of the people around us? What's the tone of somebody's voice? What's the lighting in the room? It can be anything.
It's a good point. Yeah. So you really got to look at all the sensory information.
Yeah, I think that we forget that psychosis and mental health in general does not exist within a vacuum. Like a lot of a lot of the time it feels easier to say, "Oh, okay, your brain's broken. Here's a medication." Medication is awesome. Only
Uh,
about 2/3 of individuals with psychosis respond to typical antipsychotics. So relying solely on that medication without looking at the environment that the person's in and how they grew up is kind of a disservice. So it's
yeah. And I think you're
important.
kind of describing it, but what's the best way to destigmatize psychosis care? What's that look like?
Yeah. I think that it's a hard question to answer because there is so much work to be done. And I think that starting with just having the conversation with people is huge. And in the field, I think education within the field is going to be a good place to at least start so that the helpers are informed on how to approach this. And then just out into the community saying like, "It is not what you think it is. Like, here's what's actually happening." It
hmm
can it can make such a huge difference for folks to feel accepted.
Yeah. How many people with a psychosis episode are functioning in terms of being employed or not being able to do that? What do you think that's like? And I realize you're in a community health situation that might skew things a little bit too, but
Yeah, so the program that I work in is really wonderful. We have wraparound services. So they have a supported education and employment specialist who really works with people to get jobs. Employment can be a big protective factor for folks too, because it can give them a sense of meaning. Recovery can definitely involve that type of functioning. And I think it's also important to recognize that recovery is going to look different for each person with psychosis.
Mm-hmm. Um, what would you say, and I know this is kind of a pointed question, but what would you say is success when working with psychosis?
Safety and personal fulfillment. I've thought about that one so
Mm-hmm.
much because I have people who they don't respond to medication and they might have these symptoms for the rest of their life. They might be arguing with someone on the street. And how is that impacting them and their environment? If somebody is living a happy and fulfilling life and they're not hurting themselves or anyone else, I am happy as anything. Like, that is
Mm-hmm.
recovery to me.
And do you feel like somebody, maybe they don't respond to medication, but are they going to be long term for therapy, long term for ongoing care?
Probably. Yeah.
Mm-hmm.
I mean, I'm always one to encourage long term care. I think that keeping up with someone the same way that a PCP sees a patient
Sure.
can be really helpful.
Yeah, that's a good analogy. That's a good analogy. When you work with clients, is there any particular modalities you use or you find helpful?
Yeah. Yeah. So I have an interesting approach. I very much like to combine somatic, narrative, and person centered, culturally responsive techniques, which are a whole lot of words. Basically, I like to sit down with someone, connect person to person, use my presence to show that there's some kind of safety, slowly work to gain trust,
Mm-hmm.
and help the person connect with the parts of themselves that aren't necessarily the illness, which takes a lot of combined modalities. It's hard
Yeah.
because I'm definitely not a modality purist. I have run DBT groups. I'm not a huge DBT person,
Mm-hmm.
but my goodness, am I going to make you choose the cope ahead skill? Like, I think that
Yeah.
that's great. Wise mind, awesome.
Do you
I
think
love
DBT is pretty heavy for that? Don't you think? I mean, I'm guessing that's a big one for psychosis.
DBT definitely can be. The behavioral therapies can be challenging and useful. There's CBTP, which is cognitive behavioral therapy adapted for psychosis, which is very cool. There's IRT, individual resiliency training, which has a bunch of modules teaching people about the illness, helping them figure out what they can do, and a
What is?
lot of, yeah.
Oh, go ahead. I'm sorry.
Oh, yeah, no, it's okay. Um, so using those concrete tools alongside the rapport building, safety seeking techniques
What
can
about
be,
narrative? You mentioned narrative. How does that fit with this? So I'm
yeah.
not super familiar with it, but
Yeah, the techniques that I pull from narrative is really analyzing and restructuring how somebody tells the story of their life. And when you're not connected to reality, those stories wander. And then when someone experiences so much shame and stigma, it's already enough that these voices might be saying awful things to them. Then they're saying awful things to them too. So using narrative to tell an accurate and compassionate story and ground oneself in reality, it's an interesting and can be a really fun tool.
Hmm. Yeah, that's a great way to put it. So it sounds like, Camryn, if I'm getting this right, as you're proceeding with your career, this is going to be a major part of it.
I hope so, yeah. I did not foresee it, but I love this work. I love this population, and I would encourage more people to look into it, do your research, meet someone with psychosis. They're awesome. Like,
Yeah.
just people.
Is there a shortage in the field for people to work in this? I'm just like, there's a lot of shortages for people to work with children. Do you find that to be the case with psychosis, do you think, or?
Definitely. Definitely. A lot of people avoid the population because, again, lack of research. It's hard to know exactly what to do. It's a very serious mental illness. The work can be hard. It can be hard, especially when you care so much about these people emotionally. It's tough to watch them struggle, and it's it's something that we're definitely lacking in the field.
Yeah, yeah, for sure. Well, I'm glad you're able to bring some light to that by talking today about it.
No, thank you for engaging.
You bet. As we kind of wrap it up, is there anything you would like listeners to know about that maybe we haven't touched on? I think you've been very thorough, but is there anything we might have missed? Or kind of a closing thought about it?
Yeah. I I think I would encourage people to reflect on how reality can be experienced so differently for every single person, and connection to it can really be a spectrum. People who are more disconnected from reality than others are no less human and have no less potential than anyone else.
Oh, that's wonderful. Well, we appreciate your being here today, Camryn, and talking about a topic that isn't talked about much. And it's not one of the popular things to do in mental health, right? It's
Yeah.
definitely one, as I listen to you describe it, one where you really got to roll your sleeves up and get to work with this population, with people that are struggling with this. So thank you so much for shedding light on that. It's been great, and time has just flown by. So
I know.
yeah, let's maybe talk down the road or come back on again and tell us what the latest is on this stuff, because I have a feeling you're constantly on top of this field.
Always happy to share.
Yeah. Well, again, thanks so much, Camryn, and we will talk again, hopefully.
Great. Thanks for having me.
You bet.
I hope you enjoyed that episode of Meet Your Mental Helper. I learned a lot. I hope you did too. If you'd like to learn more about our guest, you can find them on our guest directory at meetyourmentalhelper.com. You can find their social media links to follow them and also ways to directly contact them. If you would like to be on the podcast, join our Meet Your Mental Helper network. And we have several memberships that support the work we do that allow unknown experts to be seen. Look forward to hearing from you soon and see you at our next podcast.